gives me great pleasure to give a welcome, Céad Míle Fáilte, to our final speaker of the morning session, Dr. Dimitra Panteli, who leads on innovation at the European Observatory on Health Systems and Policy, and the department works very closely with the Observatory on a number of projects over a number of years. Dimitra studied medicine and public health and has been working in health systems research for over 15 years. We're just commenting when she arrived. I think she currently lives and teaches in Germany, but some of the time, yes, but also has a Greek heritage. So I think we give her credit for bringing the lovely sunshine to us here this morning. So I'm delighted to hear more from her now on that international evidence about improving patient safety and transforming healthcare delivery. Thank you, Dimitra.
Thank you very much, Céad, and everyone. In any case, I can start by saying a very warm thank you from my side for having me here. As Céad mentioned, I work with the European Observatory on Health Systems and Policies. We are a partnership that's hosted by the World Health Organization, but we have a range of important partners, including Ireland, and we're delighted about that. Our role is to be knowledge brokers, so basically try to package evidence into formats that can be absorbed into policy decision making. And one of our core functions or key functions lies in trying to understand and monitor how health systems work, how they evolve, and how they perform, meaning if and to what extent they achieve their intended goals. I would like to start today by pointing out something that you all know from the inside, namely that safety is a crucial, central part of a well-performing health system. I will show you on the first slide here, and it's a complex graph, so you don't need to worry about it so much. This is one of our newest frameworks for thinking about health system performance assessment in relation to universal health coverage, so the extent to which health systems as they function with their 4 core functions on the left-hand side of the slide, namely delivering services, raising the right resources to do that, and the right financing to do that, and having a governance that underpins all of that and puts everything together. How on the way to achieving their final goals, which is the green part of the rectangle in the middle, on the right-hand side of the white rectangle, namely improved health, financial protection, and patient-centeredness, very crucially have to ensure the intermediate objective of safe care. So this is just to show that even in frameworks that are used worldwide, this is a global framework, safety plays a key role. We see that reflected increasingly in the last few years, also in the world of the World Health Organization. The World Health Assembly in 2019 had the resolution on global patient safety action. In 2021, 2 years later, the action plan for 2020 to 2030. So very clearly increased engagement in patient safety, which we really appreciate, especially given its central nature. We heard also from the previous speakers. A few years ago, we carried out at the Observatory an umbrella study looking at different ways to improve quality of care, and within, of course, quality, we also understood the element of safety. We looked at different ways and different strategies that countries employ to improve patient safety, zeroed in on patient safety culture, and I'll come back to that because we heard it already, of how important culture is. I'll come back to that in a second. And so all of these slides are not meant to be eye tests. We're not at the ophthalmologist. It's just to show you the different components. So we identified in that book a range of different strategies based also on work from our colleagues at the OECD. 3 different levels: the system level, where you overall have the strategy and know what you want to do; the organizational level, with different organizations working within the system, in particular healthcare delivery organizations, have different things to do when it comes to implementing safety strategies, and then of course the clinical level, the everyday work between those who see patients and the patients themselves. Critically, this dimension of the patients that we don't see comes in here as well, but we can talk about that a little bit further down the line. All of these strategies They have to be combined, they have to work at different levels. So what we conclude in that chapter, I wanted to show you also that part of the system level strategies, importantly, is electronic health records. And I know we're having that discussion in a lot of countries at the moment, including Ireland, and how we move forward. So we come back to the electronic health records issue in a minute. What we conclude is that there is a range of different strategies that we need to employ. This is what we see also from knowledge from different countries coming in. At the national level, patient safety strategies based on a systems perspective, so encompassing all these different elements together, with clear focus on professional education, evidence-based safety standards, and the possibility for blame-free reporting of adverse events, really also crucial for patient safety culture. And because of all these indispensable factors that are multifold, as we see here, leadership at all levels of the health system, and this is the bit in bold at the bottom, is really important. Why do we bring that up, the leadership element? The next slide is even more complex, you really don't need to worry about it, is in the concept of patient safety. It's a STAMP model adapted to patient safety, so basically the accident model from a health systems perspective, the different levels where we have to take action, how all these different levels might work together. And the reason I'm showing you this is because if we start with the starting point that we have so many different elements that we need to combine to ensure that we move forward well in safety. The one thing that we really need to get right, and this reflects both what Bernard and Robert were talking about, is governance. So strong governance mechanisms that align all these elements together and allow us to figure out where we might be doing better, where we might be doing maybe not so well, and adjust accordingly. Colleagues at the Observatory a few years ago developed the so-called TAPIC framework for governance. Maybe some of you will have heard of it, maybe not. If not, don't worry. It's clearly, I think, also has this catchy, perhaps, name because it brings together these 5 different elements: transparency, accountability, participation, integrity, and capacity. Meaning that the health system and decision makers have to justify, to first of all share that they're taking decisions and how they're taking them. Actors taking decisions within the system and acting have to have clear roles, and there have to be clear consequences if they don't fulfill these roles. People who are, or stakeholders who are impacted by different policies have to be involved in the development and the implementation of these policies. We heard about patient participation just now. Integrity, meaning that in the system, the clear roles and responsibilities are there, and that we are sure that the people who are in positions of power are there for meritocratic reasons and act with the best interest of the system in place. And of course, capacity is having the right people and the right resources within the system to create policies, but also to monitor their implementation and see how we adapt them. Colleagues at the OECD took the TAPIC framework and mapped on it the different elements of patient safety strategies that I was showing you earlier. So they very clearly see the interlapping element of patient safety and governance. And of course, all of these different elements, most all of them we heard referred to already. I will focus on 2 columns, accountability and integrity. In the accountability column, we see these different options of provider financial incentives and penalties to promote and ensure safety. Here, we can think about that, we need to discuss. We see different countries doing it, obviously linked to also non-punitive culture in general. Routine public reporting, which we will see in a moment, is not that routine in the majority of countries. And also that safety elements are within purchasing arrangements the way they look in different countries. If we look at the integrity column, so the one before last, we have national legislation on quality and safety agency, safety standards, and patient safety programs, all at the national level, at least here in the OECD paradigm. We see that in some countries that is not the case at the national level. It might be the case in the sub-national level, and I think we'll have a discussion about decentralization later in the panel, but all of those are important. I single out these 2 elements, accountability and integrity, not because they're more important than the others, but because I think they're crucial for the discussion in patient safety as well, and the logic behind it. And what I would like to show you here very briefly is that, and here again, you don't need to read all the countries. Look at how many black dots and how many white dots we have. Some countries are doing better. These are the functions reported as implemented to have clear roles and responsibilities. So here we are in the integrity side of things. So if you see at the overall picture, some countries are doing better, Ireland here has 3 out of 4. It's 2019 data, so things may have changed in the meantime. And if we look at the dimension of key accountability, so the accountability element, here as well we see that some countries are doing better than others within Europe, but also outside Europe, and again with Ireland doing comparatively better than others. So what we need to think about is how this picture then translates in where we can learn in our setting here from others and where that might make the most sense, given on perhaps who is doing better, but also how our health system is set up. I come back to that in a minute, because here we're still quite normative. Have these strategies been implemented in different countries? What we see, if we take a global sum of things and we look at the global picture, we have a new report from the WHO on global safety, patient safety. We see, again, that in some areas, like for example, having national targets or having a national strategy for patient safety, we have more or less about 40% of countries worldwide displaying that, but then we have other bits, like the 13% is having patient representatives within decision-making processes and within decision-making bodies. So we see this is definitely an area that's lagging behind and where we need to pick up. And also importantly, if we look at the different areas within healthcare delivery where systems have been focusing on patient safety, we see, and I highlight the European region here, that perhaps unsurprisingly, the majority of countries, and this is share of countries out of everyone who have implemented initiatives on safety, have some initiatives on surgical care, on gynecological and obstetric care, much less perhaps intuitively in things like oral health or eye care, but that's also not to be neglected, and especially not as much in ambulatory care, which, if we're thinking about moving care from the hospital setting into the community, is something that we really need to think about very carefully. Like, where are we focusing our efforts? And this is something that we also see in the work of the OECD, that in general, patient safety initiatives are usually focused on the clinical level and at the hospital setting, and less on the perhaps in the other settings. So this is something that we really need to think about. So far, we've looked at on the slides at different things that, or different dimensions of patient safety that we can address more normatively. So what is being done? Does it work differently there? So do countries that have, for example, more black dots on the table have better patient safety outcomes? So if we look on the outcome side of things, we have from Imperial College the Global State of Patient Safety. That's from 2023, so relatively new data. And we see here a relatively simple, I would say, of course it's not easy to do, so don't get me wrong and don't quote me on saying this, but just intuitive way of looking at it. Patient safety country ranking that ranks countries. This is always very difficult to do because it's fraught with limitations, measured in standard deviations from the average. So if the further to the right this is, the better you're doing, the further to the left it is, the worse you're doing. Ireland, as you can see, is not doing all that badly in comparison. It's definitely in the top half. Germany is the average for some reason. But we also see, and this is important to note, because we heard about the crucial dimension of measurement, and I will bring that back in a minute, that this is an indicator. The ranking is based on a measure that combines 4 indicators: maternal mortality, treatable mortality, adverse effects of medical treatment, and neonatal disorders, and is measured by deaths. Right, so this is operationalized that way because the data that way is more reliable. Deaths are coded in a way more reliably than other outcomes, but it also means that it's a very specific thing that we're looking at. So based on these 4 elements with this composite indicator, this is the way that we see countries ranking. Perhaps interesting for the discussions that we're going to have afterwards is that Norway is leading with the best performance here. And they delegated responsibilities across the system to the regional health authorities and other actors within the system quite strongly in 2017, in a departure from what they had been doing up until that point. So this issue of centralization versus decentralization is something that we can discuss. So if we look at this data then, do we assume that Norway is doing great in patient safety and that Ireland is doing fine but needs to catch up with Norway, and that here, sorry, apologies, Mexico all the way down is not not doing well at all. We can, but of course we are looking here only at this metric. If we look at other metrics, and this is the survey that was carried out by the OECD as the pilot survey. If you look here at the top, we have paid on the right-hand side, top figure 2.1, patients reporting that patient safety incident occurred during treatment of care. And if you see Norway, it's close to the middle of the graph. Here you want to have as little as possible. It's not doing that great compared to the other countries in there. Or if you look at the bottom graph, patients reporting that they got information about what symptoms or health problems to watch out for after hospital discharge. Here you want to have as high a percentage as possible. Norway, again, is not among the leaders. It's just to say, when we conclude in terms of where to learn from and what to take away, we really need to be careful about what we're looking at. And also here, if you think about the difference between the data underpinning the previous graph or the graph on the left, which is more on the death side and more on the routine data side, and here on the survey side, this is something to think about as well. We heard very briefly before, not that briefly, but definitely picked up on the issue of digitalization, and especially if we think about how important it is to have a good digital infrastructure in order to have good data, in order to be able to have good measurements, in order to be able to have a very robust understanding of what is happening and move towards improving. There is this question of how much digitalization can help and contribute to patient safety. I picked this up here at the example of electronic health records because this is a fundamental prerequisite, but we also heard about different elements just now. For example, the virtual wards pilot, there are really wonderful posters outside that look at telemedicine and how it can improve different digital medical devices and how they can contribute. So just to say, it's electronic health records here, but it's definitely not only that. The point that I want to make here is that just as with data, where it's important to have them, it's important to look at them, monitor and see how we can improve. Also with policies, like for example, really investing in electronic health records, they are, and they have proven to be in research, I will show you in a minute, a couple of headlines, very promising for strengthening patient safety, not only intuitively, for example, for reducing medication errors, but also perhaps for improving processes in healthcare, also time saving so that clinicians can do other things and focus more on patient safety. However, the devil is in the details. So what we see quite a bit in the research is that potentially, if you don't do your interface the right way, EHR fatigue can contribute to worse patient safety outcomes or complicate it further. And so there is there as well quite a lot of evidence collecting from different parts of the world on how we can do it to make it clearly. I will just mention very briefly, because I would not be able to mention digitalization without mentioning that, artificial intelligence. This is the next step of how we can think about working towards patient safety. Here as well, similarly, we have a range of test areas and test cases or possible areas where AI can help, not just in terms of prediction, drawing from data on EHR, in terms of also in different areas like sepsis prediction or suicide prediction even, and we heard about mental health just before, but also for diagnostic safety. Here too, very clearly, we know AI has a number of limitations, and the way that they apply to everything else that we employ it for in healthcare or hope to employ it for patient safety is the same. So we need to be aware if that is, for example, equity dimensions or the potential of false positives that actually complicate more than help health processes. That's something to consider. I will finish or wrap up very quickly with one key consideration. We did some work last year for the Tallinn conference on strengthening health systems that looked at what we really need to transform health service delivery, and especially what policymakers can do. And we came up with a complicated framework, which is also on the slide, but I'm not going to show it to you because of time. But effectively what we said is that when we think about decision making, so policymakers, be that at the national level or the subnational level, what they can do for transformation of service delivery is really have the vision and the strategy, and then making sure that people on the ground can actually implement the strategy into everyday practice. And that means having the right money, having the right people, having the right technologies and the right information. And around all of that are the governance levers that will help you make work. So payment mechanisms, different types of standards, all the different facilitators that we need to ensure that those working on the ground can actually implement the change that we want. We heard about the challenge of implementation just now, and it's really an issue. But what I want you to take away from the complicated framework on the right-hand side of the slide is the central little bit about leadership and political will, and the crucial part that is tied with it, which is stakeholder engagement. I showed you earlier on the global overview that this is the part where most countries in the world struggle with, which is patient engagement and patient safety. If we look at the OECD data, there as well, different dimensions of patient engagement. Ireland is doing the greener and the darker green you are, the better it is. So Ireland is doing relatively well, but there are others who are doing relatively better. And the one country that sticks out here is third from the top, greener, is Canada. They have really interesting approaches and really interesting resources that we can look at. So this would be a very clear example of where do I look at to learn about this. It's also a federated, decentralized system that can give us ideas of how we can do that at different levels within the system as well. And finally, just to go back to what we were talking about, turn your badge around. We have the Patient Safety Rights Charter. There are a number of actions there for which patient engagement, of course, is crucial. But of course, it's not just about paying lip service to it and saying that we're doing it. It's also about getting it right. And in that sense, these different dimensions of depth, like informing, yes, consulting, yes, but also partnering with patients to actually make sure that all the actions that we take lead to better patient safety outcomes is really important. And this comes to us not just from the evidence that we see in our everyday work, but also the international discussions that we have with other experts. I wrap up at that. I think I'm relatively okay with time. Thank you.